Hi, my name is Miya Yoshida. I'd first like to thank SAGES for giving us the opportunity to present here. I'll be presenting our results on the predictors for failure to complete laparoscopic total cholecystectomy. We, the authors, have nothing to disclose. So laparoscopic cholecystectomy is currently considered the standard of care for gallbladder disease. However, in recent decades, guidelines have recommended that when unable to obtain the critical view of safety, a planned laparoscopic cholecystectomy should be converted to a bailout, which is either conversion to open or subtotal cholecystectomy. We analyzed both patient and surgeon characteristics that might predict need for bailout within our institution. We performed a retrospective single institution review from January 2016 to August 2019. For this study, we included all patients who underwent a cholecystectomy for biliary disease and excluded patients with a concurrent operation, malignancy, planned as an open cholecystectomy, or was performed by a low-volume surgeon, who we defined as performing fewer than 50 surgeries or 50 cholecystectomies during the study period. We then performed univariable as well as multivariable analysis using hierarchical logistic regression models to find factors associated with bailout. We identified 2,818 patients who underwent a cholecystectomy during this period. 159 patients were excluded from the study based on criteria. We then separated the remaining patients into two cohorts, those who underwent a laparoscopic total cholecystectomy, or LTC, and those who underwent a bailout surgery, or bailout cholecystectomy, BOC. In this graph, the frequency of laparoscopic subtotal and open cholecystectomy stayed about the same over the last 3 years, with the rates of lap subtotal being higher every year at about 4 to 6% versus 0.4 to 0.7% open. While there was no significant trend, it is notable that the rate of open conversions consistently decreased over the study period. In general, our group of surgeons showed a tendency toward performing subtotal cholecystectomies via laparoscopic approach. On univariable analysis of patient characteristics, we found that the bailout patients had more comorbidities and more evidence of inflammation. Median age for patients who underwent a bailout procedure was 62. The majority were also male at about 62%. Nearly a third had diabetes and more than half had hypertension. 42% had an ASA class of 3 or higher, and about a third of the bailout patients presented with a longer duration of symptoms, and nearly 3/4 of the patients had documented tenderness in the right upper quadrant on physical exam. A higher proportion of patients in the bailout cohort exhibited signs of biliary inflammation, which is evidenced by increased leukocytosis, tachycardia, bilirubinemia, CBD dilation, and gallbladder wall thickening, as seen on ultrasound. In addition, 76% were reported to have adhesions in the upper abdomen during surgery. Although most of these characteristics have previously been identified in the literature, this data further confirms the idea that the bailout cholecystectomy patients were likely higher risk prior to surgery. In terms of outcomes, the overall complication rate for the bailout group was 9 times higher than the laparoscopic total cholecystectomy group. The bailout cohort had higher rates for any complication, including surgical site infection, bile leak, retained stone, as well as length of stay, OR time, and secondary intervention, which included endoscopic and IR procedures. Bile leak was the most common complication among the bailout cholecystectomies, closely followed by secondary intervention, the majority of which were postoperative ERCP. Operative time was also significantly higher in the bailout cohort by almost 1 hour, and the only 30-day mortality occurred in the bailout group at 1%. These findings are likely due to the sicker nature of the bailout patients on presentation to the hospital. We also looked at a subgroup of our cohort focusing only on inpatient cholecystectomies, since they had the most complete data set. We performed a hierarchical multivariable regression using patient and surgeon factors that were found to be significant on univariable analysis. We observed that male patients, those with tachycardia, a preoperative diagnosis of acute cholecystitis, symptoms of 3 days or longer, right upper quadrant tenderness, CBD dilation, total bilirubin of 4 or higher, and intraoperative adhesions were at higher risk to undergo a bailout procedure. The presence of adhesions was the highest independent risk factor at an 11-fold increased risk for bailing out. Amongst the surgeon factors we looked at, a bailout rate of 7% or higher was the only significant risk factor for conversion to bailout. We also looked at case numbers, years of experience, and operative time, all of which were not significant. Unique to our study is the identification of a single surgeon factor, namely how frequently the surgeon performed a bailout. While the 7% cutoff is potentially unique to our institution, our analysis reveals the possible effect of surgeon preference as an independent risk for bailing out. To conclude, we found that the average bailout rate at our institution was about 8% uniformly across the 3 years during the study period, comparable to what's currently reported in the literature. Again, as is well described, complication rates were higher for those in the bailout cohort. We observed that several patient factors and higher surgeon bailout rate were independently associated with conversion to any bailout procedure. And we hope that our results will motivate developing models for performing bailouts that minimize injuries in difficult gallbladders while also decreasing resulting comorbidities. Thank you.